So the relation of hypertension and heart failure is almost thorough. The heart failure and hypertension can lead to each other. Of course, the hypertension can lead to heart failure more than the contrary. They share most of the pathophysiology, neurohormonal changes and changes upon the heart, and they almost share the same pharmacological treatment: RAS blockade, the beta blockers, the MRAs, and diuretics. And in the journey to try to decrease the risk of heart failure, we find and innovate every day another novel treatment to treat heart failure, including now sacubitril, valsartan, and SGLT2 inhibitors. And these drugs are now officially treatment of heart failure. They decrease the blood volume, they induce vasodilation. So the questions are, what's their effects on blood pressure, and whether we can depend on them or consider them antihypertensive agents or not. So let's find out. For the SGLT2 inhibitors, they decrease the absorption of glucose and sodium from the proximal convoluted tubules of the kidney. So they induce glucosuria and natriuresis, and they increase the use of energy in the heart. So they do have diuresis, natriuresis, decrease the afterload, and increase the myocardial consumption of energy, improving the contractility functions of the heart. So, is there any role other than heart failure for this group upon the heart? Actually, you will be dazzled that there is a wealth of trials that studied the effects of these drugs on hypertension, whether on office blood pressure or ambulatory blood pressure, starting from the dapagliflozin, the empagliflozin, and the canagliflozin. And the more accurate 8 trials that I'm showing now are comparing the effect of these drugs on the ambulatory blood pressure, whether systolic or diastolic. And they found that when using these drugs to treat hypertensive diabetic patient, there is a significant decrease in both systolic and diastolic ambulatory blood pressure rather than the conventional anti-diabetic treatment. And in the study of dapagliflozin, DAPA-HF, on heart failure, the subgroup analysis with hypertension showed that the higher the blood pressure, the more the benefit they get from the decrease or the antihypertensive effects of the dapagliflozin. So any patient, diabetic, hypertensive, and heart failure that has a systolic blood pressure more than 130 millimeter mercury will benefit more and will have a significant decrease in his systolic blood pressure than the modest group or the controlled group. And if we plot these data, we can show that we can achieve a decrease in the systolic blood pressure up to 10 millimeter mercury and diastolic blood pressure up to 6 millimeter mercury when using these agents in addition to the conventional antihypertensive medications. So who will benefit most? Of course, the diabetics, hypertensive patient will benefit most. The patient known that they are salt sensitive will benefit most because the initial mechanism is increasing natriuresis and glucosuria. And patient with decreased blood pressure dipping will benefit more from the effects of these drugs upon hypertension. And the golden question is, should we depend on this drug or consider this drug an anti-hypertensive drug? The answer is no, because there is no enough data comparing this drug to an antihypertensive group. It's only an additive effect. So we cannot depend on them as an antihypertensives. We can rely on their additive effect on decreasing blood pressure. And here come the sacubitril valsartan, which is strange enough considered first an anti-heart failure and not an antihypertensive medication. It includes both the blockage of AT1 receptor, the ARB effect, increasing vasodilation, decreasing blood pressure, decreasing sympathetic tone, and by the neprilysin inhibition, it increases the pro-BNP, which does exactly the same and in additive increase natriuresis. So it's logic that this agent or this group of drugs do affect blood pressure in a considerable way. But the famous heart failure trials upon the LCZ 696 did not address this issue in particular. The Paradigm heart failure, the Paramount, and Pioneer did not compare the antihypertensive effects of these drugs. So we cannot rely upon them in extrapolating important or accurate data. But this meta-analysis issued in this year, in January this year, compared 12 trials that address in particular the effect of LCZ 696 upon hypertension, comparing it to antihypertensive ARB medication. They compared all the doses of LCZ 696, 100, 200, and 400 milligram against valsartan, starting from 80 to 320 milligram, or olmesartan, 20 milligram and 40 milligram. And it's logic that the effect of neprilysin adding to valsartan will have a superiority of these agents or the LCZ 696 upon valsartan or olmesartan in every dose, starting from 100 milligram, 200 milligram, or 400 milligram. And it's also logic that the more dose I acquire from the LCZ 696, the greater the effect on the blood pressure. And it seems without a considerable complication. This drug is tolerated well by the patients. But there is limitation of these data. First, 5 of these trials were extrapolated from the Novartis medical data, and it's not published in scientific articles. So the results of them are not relying upon. Trials have a short follow-up period, maximum for 12 weeks, so we cannot guarantee the long-term effects of this drug. And the type of doses of ARBs were extremely variable, whether with the type of ARB, valsartan or olmesartan, and the doses varying from 20 to 40 milligram in olmesartan and from 80 to 320 milligram in valsartan. And the sample size for the lower doses, 100 and 200 milligram, were small. So before considering it as a monotherapy, we need more randomized controlled trial for both groups, especially for LCZ 696, because of the tolerability and the greater effect on blood pressure. We should know what's the long-term complication of this drug upon hypertension, and most important, the cost-benefit of these expensive drugs when using as monotherapy for hypertension. So in summary, novel agents treating heart failure, the SGLT2 inhibitors and LCZ 696, also have an antihypertensive effect. These effects are not related to heart failure. They vary according to the treating group and dose. More trials are needed before considering any of them as monotherapy for hypertension. And thank you so much.
Thank you, Dr. Soliman. Dr. Haytham, for this excellent presentation, I would like to ask about the effect of these novel drugs on renal events or renal affections in patients with heart failure, especially in the meta-analysis of randomized controlled trials.
Okay, the SGLT2 inhibitors have beneficial effects on the renal functions of the patients, whether they are hypertensive or non-hypertensive, extrapolated from both the heart failure trials and the hypertensive trials, and now they have dedicated trials for renal patients and heart failure. The LCZ 696 has a more gray zone, so that's why we have to have more randomized control trials with larger follow-up period, because the valsartan group or part of the LCZ 696 do affect the renal functions. So we do not have efficient evidence about the higher dose, the 400 milligram of LCZ 696, with the long-term affection of the renal functions. So these drugs at the short term do not affect the renal functions, do not worsen the renal functions, but they need a longer term follow-up trials to be sure that they are safe.
شكرا دكتور هيثم على المحاضرة القيمة ديت. أنا الحقيقة لما شفت عنوان المحاضرة كاتب يعني مكتوبين effects of novel drugs في الهارت فيلر على الهايبرتنشن، كنت فاكر إنها لها يعني نيجاتيف إيفكت. ده الامبريشن يعني يمكن من العنوان بيقول كده، فأنت قلت لنا maybe beneficial، الحاجات الجديدة maybe beneficial for hypertension. يا ريت توضح البوينت دي.
لا معلش انا ما سمعتش حضرتك كويس. ايه
هو مش سؤال، هو زي ما بقول لحضرتك ما نكتب نقول الافكتس اوف نوفل دراجز في الهارت فيلير على الهايبرتنشن، يعني is my impression, this is my own impression انها it will be deleterious or hazardous for hypertension. It is not beneficial. It's your comment.
My comment is any drug that affect heart failure, hypertension, can be deleterious if it's not used by its proper dose. So knowing that these novel agents have an effect on heart failure, on hypertension, will make us more careful in using these drugs and in up-titrating the doses of these drugs when treating patients, diabetics with heart failure and hypertension, or heart failure patient with or without hypertension. So knowing that these drugs have a potent effect on blood pressure will make us more careful in treating these patients and following up these patients.
Any questions from my colleagues? Doctor?
One more question, please. Is it wise to use diuretic in these GLITS2 and valsartan sacubitril?
Well, by the guidelines, sacubitril valsartan is used at the stabilization of heart failure patients. So it's advisable not to combine the diuretics with the LCZ 696 in patients with heart failure. So it's drug for chronic heart failure or stable heart failure patient, not for acute heart failure. So supposingly we will not use or need to use diuretics in these patients while using the LCZ 696.
At what time we can use these two mode of therapy indication? Because the cost benefit is great. You know the cost of these drugs.
So
when you think about the use of these drugs as the hypotensive drugs,
the golden patient for these drugs, especially the early, is the patient with resistant hypertension and heart failure. And the more suitable patient is the patient with sustained resistant hypertension who got heart failure from the hypertension. This is the most suitable patient who will benefit from the higher doses of these drugs, and the cost will be logic at that time. We are treating two major problems for the patient with one drug. Yes, now we are using this drug in two indications that they are not originally meant to be. The antihypertensive effect of the drug and the heart failure with preserved ejection fraction. We have already established studies to show the benefit of these agents in heart failure with preserved ejection fraction. And we are waiting for more studies to show the benefit in hypertension. So it's logic to combine the benefit of both in a patient with hypertension complicated with heart failure or an initial heart failure patient with resistant hypertension.
Thank you very much, dear Professor.